How do we detect a PDA by echo? We will use the short axis view. We see here the aorta, we see the pulmonary artery. With the branches, we see the aorta. And again, color is very helpful to confirm that there is shunt from the aorta into the pulmonary artery. Suprasternal views can also be used, and we can there see again the flow from the aorta into the pulmonary artery. But the most helpful view is certainly the short axis view. This is a typical example of a patient with a small PDA without hemodynamic significance. In the short axis view, we can nicely see that there is indeed a PDA, but looking at the left ventricle, we see this is a normally sized left ventricle with normal function, so certainly no signs of left ventricular volume overload. We have a normal right ventricle, just from the ventricle, no signs of pressure overload, and when we use continuous wave Doppler and measure the velocity of this PDA jet, we see that we have very high continuous velocities, and this indicates that we have continuously a high gradient between the aorta and the pulmonary artery, and this patient has no has a PDA with no hemodynamic significance, and it's not really clear whether these patients need closure. Another patient here with, again, continuous left to right shunt via a PDA, but we can see here's the mark with 3 meters, that this is a much lower velocity, already indicating that there must be an elevated pulmonary artery pressure. Now we could again use the Bernoulli equation, calculate the peak velocity of the PDA jet, and using the systemic pressure non-invasively measured to calculate the pulmonary artery pressure. Again, this is not entirely accurate, but it gives at least some impression whether there is a normal or moderately or severely elevated pulmonary artery pressure. This is a patient with a large left ventricle, and still, even the contractility may no longer be normal. We can appreciate that this is certainly a left ventricle with volume overload, a patient with a large PDA, and this patient, already adult, has not developed severe pulmonary hypertension and has primarily developed left heart failure. And these are the patients who can ideally be treated with PDA closure still in adult life. And we see the same patient on the right-hand side after closure. The size of the left ventricle has normalized, the ventricular function is normal, and the symptoms completely disappeared. So this is the ideal situation for closure, and the patients will have the most benefit. Now, the other group of patients with significant shunt in adulthood who have not yet developed Eisenmenger syndrome are those, we'll see this in the next views, with predominant signs of right ventricular pressure overload due to development of pulmonary arterial hypertension, but we see that this patient is the same spectrum we have seen before, still has continuous left to right shunt. So this is a patient who has not developed Eisenmenger syndrome. We see it also from the color image and can appreciate that there is continuous left to right shunt. Still a nice jet seen here. We see the very severely dilated pulmonary arteries. And this is a patient who still benefited from closure. The pulmonary artery pressure decreased and the symptoms improved, but these patients need careful evaluation before the decision whether to close the PDA or not.